Good morning, and thank you to Diane for inviting me to participate in this workshop. I have no disclosures. Just to set the scene in what I do, I'm a nurse consultant and I work across Cornwall, which is the toe of England. My clinical setting is seeing children, young people and adults. So in terms of catheterization, I'll teach children to do intermittently catheterize and adults. In terms of indwelling urinary catheters, we're getting more children now with complicated indwelling urinary catheters. And so I'm involved in those cases and also providing a resource and some education for a whole range of healthcare professionals out in the community who are delivering most of the insertions of indwelling urinary catheters. And most of the calls I have every week are from community hospitals. For example, I'm discharging patient today, they get wet overnight, can I put a catheter in? So there are these types of scenarios. So that actually then yields a lot of discussion to say, well, what's happened in the last 6 weeks with the patients being with you? So it's a lot of education. But what I want to focus on today is really where guidelines sit in all this. So recognizing the drivers towards clinical guidelines, understanding what makes a good clinical guideline, and appreciate the similarities and differences between some of them that are available to us. Now, the guideline production, what we know is that there are huge amounts of them. The sources are wide and varied, and I've done lots of searches on this in preparation for this presentation, but there's actually very few that are very global. They may be sort of for a particular hospital, an institution, an organization, but there are not many that actually cross a continent. There are differences between guidelines and pathways, and just to remind ourselves, guidelines really should be underpinned by systematic reviews of the clinical evidence and as a main source of the evidence-based care, whereas pathways are structured multidisciplinary plans of care that actually are a stepwise sequence. Now, what I've found in the opinion articles, not necessarily the scientific literature, is the growing concern of conflicts of interests in developing guidelines, and actually, do they make a difference? So what does make up a good clinical guideline? A review of the literature, being reliable and reproducible, clinical applicability and flexibility, having clarity. It actually includes all the healthcare professionals and stakeholders involved, and it has a review, so it doesn't sit on a shelf and is actually outdated. Back in 1994, we had in our country effective healthcare documents that came out from York University. And it was saying back in 1994 that clinical guidelines can change practice and affect patient outcome. It's effective, active implementation, and should be based on reliable and cost effectiveness. All sounds good. So in 2004, NICE, by this time we had something in England called the National Institute for Clinical Excellence, and in Scotland we have something different called SIGN. But NICE covers England and Wales, and what they did is saying, okay, we've produced lots of guidance, let's check out, does it make a difference? And what they found through the review is that adoption of these guidelines is influenced by strong professional support, a stable and convincing evidence-based, and established good systems. However, I just want to quote to you something that came out in the British Medical Journal recently, and this was some comments from some physicians around guidance. It says, we like to stick within the standard of care because when the shit hits the fan, we all want to be able to say we were doing what everyone else was doing, even if what everyone else is doing isn't very good. So it's really important that we get these guidance right. Now, if we bring this back up to today, 2012, there was a systematic review which was very interesting because it looked at the evidence out there. There was only around 21 papers looking at, do guidelines get into practice? Does it shape what you and I do? And it says, the ultimate conclusion is, it's not clear what is the most effective strategy to implement clinical guidelines, which is quite worrying. Now, if we look at the International Consultation on Incontinence, the latest publication, they've reported in one of the chapters that although guidelines and protocols for catheter care practices are abundant, relatively few practices are supported by research evidence, and even fewer by evidence from RCTs. So why do we need to have guidance when we know that there is a gulf between having them available, and we know there are lots of them, to actually making changes in practice? Well, we know that indwelling urinary catheter, as Diane has eloquently described, is highly prevalent. 25% of IUCs may be used in acute care. And of course, some people will require antibiotics, and some of those groups will go on to have life-threatening complications. What got me interested in this was when I was a district nurse sister, one of my patients had comorbidities and was generally well, but coping within all of those. And one of my colleagues went to recatheterize this patient, and he died. She did it on Monday, and he died by the Thursday. And it was really like, oh, what the hell happened here? So we looked at the guidance that we had locally, and she'd followed everything. And so we did a significant event. And what eventually was the result is that he died of chest infection, etc. But what we don't do is actually get the root cause. And we believe the root cause was from that recatheterization on that Monday evening, because within about 6 to 12 hours he had developed a fever. And therefore then was a consequence chain event that actually ultimately led to his demise. That led me then to try to understand what's the guidance, what's best practice, and what can we do to identify risk factors. What certain groups of patients should we be very careful with? But I wasn't able to actually drill down and get this information well enough. And things do go wrong, just as I've given a description. But this here is really interesting. This has come up a lot in my area, and this came out from the National Patient Safety Agency, which is part of our NHS, and it's saying that don't put a female catheter in a male urethra. Makes sense to you and I, completely common sense, but should this ever happen? No, but it does. I think I've come across 2 now in the last 18 months. Now, we have something in the UK called never events. So therefore, you don't take off the wrong limb in surgery, and you don't leave swabs in people. Those are some examples of never events. And this, I believe, should be a never event. Because we have heard cases whereby people have been admitted into ED and actually been doubled over. Men have been doubled over in so much pain because the balloon is in their urethra. So this is something that I ask all the hospitals I in-reach to. There are 14 community hospitals and 1 or 3 secondary care hospitals. I in-reach to all of those, and I ask, do you know about the poster? Just something simple to have in their stock room. How many do you think? Very few know about it. And yet this came out a long time ago. We know that infection is a significant problem. There's lots of data, and Diane has quoted this already. And this is what I talk to the clinicians I work with and I deliver education to. And it's really trying to give them some really underpinning good information so they remember. So that when they are making that decision to catheterize, they stop and think. And when the catheter's in, that they actually critically review that every day or every shift. The key aim of all the guidance I've looked at is around reducing the duration of catheter use, and that is really the underpinning issue of reducing infection. Get these devices out as soon as possible. Now, when we look at the prevalence here, this was a survey across some of the acute hospitals in England, and it showed that on this particular survey, between couple of months in 2011, 18.8% was the general prevalence of catheters. And when I looked at this in my area, I found 26% prevalence in acute hospitals and 22% in community hospitals. So what we did is we did a weekly intervention then of capturing data, and the lowest we've ever got is 13%. And it's a lot of congratulations to the colleagues I work with because they've worked really hard to do that. We then had a financial incentive because the acute sector, well, our commissioners, actually the people who buy the provider services, said, well, bring it down to 10. Bring it down to 10%. But we couldn't do it. We just could not get down to 10%. And when I've looked at this and spoken to colleagues in England, we don't know what that prevalence figure should be. Ideally, it's around removing them as soon as possible and having as least as possible, but actually bringing it down to a particular prevalence figure has been really challenging for us. So what guidelines are available? These are just 3 of many, but actually I think have got some similarities, and this is the one that Diane referred to, and is a very good document. This one in Ireland is very good, and so is the European and Asian ones, and you probably will know of others as well. Now, NICE, going back to NICE, this is our England and Wales guideline housing system. We have now a quality statement come up for urinary catheters in our country, which is excellent. So what I'll be doing, my task is to see, are we compliant against this? But when we had some nice guidance come out about 2 or 3 years ago, there were 29 recommendations in there for best practice. Only 4 of them were grade A evidence, and 21 of those recommendations were expert opinion. And I think it goes back to what Diane was saying, is that there's not a lot of research going on. It's a difficult area to probably research very well. Now, if we look at these 3 documents that I looked at, it was judging them, well, actually picking out how do these meet some of the best practice recommendations against the 2 ICI books. One was 2009, and of course our most recent is 2013. So we looked at these, and this is what I use these in terms of the education that I deliver to my colleagues. Indwelling catheters should only be used after alternative management strategies have been considered. Duration of catheter should be minimal. Closed drainage system. Asymptomatic bacteria should not be treated with antibiotics. I have to say this one is getting really well embedded in our local area. And of course, these are grade A and B evidence. Here we have routine urine culture in an asymptomatic patient is not recommended, but we still have cases, people going into hospital who have a routine CSU or a sample of urine taken. Silver alloy catheters should be considered for short-term catheterized patients to reduce risk of CORTI. We did have an industry-led approach to say, use silver alloy catheters in your hospital for everyone and you'll reduce CORTI. But we didn't buy into that. Catheter materials designed for long-term use should be used where a catheter is expected to be long-term. And we do a lot of work on this, and there's some grade B evidence on that. Meatal cleansing with plain soap and water. I've had a colleague, a urology colleague, asking me to explain why this is so, and would still prefer to use betadine or solutions, antiseptic solutions. So it's about spreading this information. Addition of disinfectants to drainage bags, etc., are not recommended. If an indwelling catheter is being considered, suprapubic catheters should be considered a long urinary catheterization. And here's a new one. In terms of the 2013 ICI, this has been added, this in italics, because it did say suprapubic catheterization insertion should be carried out by only appropriately trained and skilled practitioners. And the 2013, what was different between the two I noticed is that urethral catheterization has been included. And of course, the catheters should be adequately supported. Now, in our acute hospitals, only recently have stabilization devices been used on the thigh. And that's a major breakthrough for us, because we would have patients walking down hospital wards with actually carrying their leg bag on their stand, and the only thing keeping them in was the balloon. So, and of course, that can lead to trauma, expulsion, etc., and probably lead to CORTI risk. So we are getting there, but again, it's around this, is an example of guidelines not reaching the points it should reach. And And here, we do a lot of the work on this of advising our clinicians not to wait to crisis, not to wait till the 5 o'clock on a Friday afternoon or for it to be out of hours for people to have problems with their catheter. We have medical colleagues who say the catheter should be in place for 12 weeks because it's a long-term catheter, therefore let's do lots of solutions and keep it going for 12 weeks. So what we say is, no, you change the catheter when proactively. Let's not wait for crisis. And of course, in terms of these specific guidance here, there are differences in terms of them. For example, in this one, it suggests that patients with urethral catheters in place for 10 years or more should be screened for bladder cancer, and I don't believe there's any consensus on that. And then the other two guidances, they do include educational issues, documentation and surveillance. Some other work that's come out which I think is really interesting, and this is what I use for colleagues, is to really point out that removing the catheter as soon as possible has the best impact on reducing CAUTI. Because they bundled these particular interventions and found that the removal of the catheter as soon as possible was the most effective. Diane's alluded to this guidance here, which is really, really useful. And we do use this as well. And it says here, for example, there's no evidence on using specially impregnated catheters in clinical practice. In fact, actually, before this particular data was released, industry were coming to see me to say, we would like you to consider using an antibiotic-impregnated catheter. And I said, well, what I'd like to do is wait for the evidence to come out that can inform my practice. And this came out, which is really interesting, from the Picard team in Newcastle upon Tyne. They looked at, in a randomized controlled trial, different catheters, standard catheters, and found there was unconvincing findings for any particular catheter. And in here was a silver and nitrofuran towing impregnated, and I think a standard PTFE. Because infection causes harm and so many other things as well, we have a driver in the UK to improve care, and so therefore we have something called the safety thermometer. So that means every month there's a lot of data that's collected by hospitals to send into the centre, into our NHS, because what they want us to do is to deliver harm-free care as defined by the absence of CAUTI. And so therefore we do weekly monitoring on this, and there's a lot of drive to be able to ensure that we reduce catheters. And so we are measured now on this. Now, there's been a lot of work, certainly from the American literature, around how can we reduce catheter use by looking at interventions, either computerized or chart reminders. So we drew from this and actually developed the stop order, which is actually, I think in America they use quite a lot. And what's really fascinating is that we have put this out, we've disseminated this to all our hospitals. And I do a monthly visit to the hospitals depending on where the highest prevalence of catheters happens to be. So every time I go, I check that they have the poster about the size of the catheter, and I check they know about this. More often than not is a, no, I haven't seen that. Can you show it to me? Can you send it to me? So even though we have sent this out ourselves, it doesn't always translate into the nurses who are delivering care knowing about this. What we find is that the ward system may know about it, but not necessarily the carers and the nurses at the bedside. Now, this is a really interesting piece of work, and it's from an English, a UK group, looking at clinical decision-making in placing catheters. And I just want to read you a quote from this, because I thought it was very interesting. Because when I see clinicians in different areas, I say, why have you got a catheter in this particular patient? They say, well, it's appropriate. So appropriate is a very broad term or word or description, but actually what is appropriate? And some of the work that's coming out now is actually teasing that out. Because it doesn't always, we can say what the indications are for using a catheter, but actually it may not be translatable to the real life of the situations that nurses may be facing. And this is from this study was qualitative, and they asked nurses who made decisions, and physicians, nurses and physicians who'd made decisions about putting a catheter in within 4 hours of that clinical decision, is to actually get their thinking aloud. Why did you do it? And then a few weeks later do a semi-structured interview. And this was from a physician about why he'd catheterized. You tend to leave it in because you're on call and you pop something in. To take it out again seems fairly nonsensical because it's only going to add to your workload later. So that physician had put a catheter in to find out what the residual urine was and then left it there. Now, of course, from the data that Diane's quoted earlier on, is that some of these catheters can then become forgotten. People are then discharged into the community and so on. So you can see the consequences. And so, therefore, this particular piece of work identified the complexity of a clinician's decision in making to place an IUC, and choices may be beyond the categories of appropriate or inappropriate. Some of the guidance that I've developed for my local area have probably about 4 or 5 indications, but that may not be meaningful to certain situations. And I think it's really interesting work. So do we need to review the guidance and make sure that it's actually truly real for the people who are facing very increasingly complex cases? And this is another piece of work that's come out from Ann Arbor, looking at, again, this appropriateness. And what they did is they used as a particular method whereby they had a group of 15 healthcare professionals, a mixture of healthcare professionals, and as reviewed the literature and gave this group of 15 professionals 299 clinical scenarios. And they had then to actually grade the appropriateness of putting a catheter in that situation. They also did intermittent catheter and also external catheterization. And what they did is they found that new appropriateness criteria can inform large-scale collaborative and bedside efforts to reduce inappropriate urinary catheter use. And this is an example. I just plucked this out. It says here, this standard was guide for Foley catheter use in hospitalized medical patients, and an appropriate indication is reduce acute severe pain with movement when other urine management strategies are difficult. So, for example, an acute unrepaired fracture. So therefore, what it's doing is teasing out some of these appropriateness issues whereby on the other appropriate guidance, the catheter shouldn't have gone in. So it's actually broadening those examples, and there's a whole list of them. What I want to do is saying, is it applicable then to put now into a guidance, is to renew our guidance. So I thought it was extremely interesting, some really good work. So what do we know? We know some of the international drivers towards clinical guidelines, what makes up a good clinical guideline. There are similarities and differences. We should recognise the opportunity to develop international standards, but I think it's also around the need for meaningfulness and transfer into practice. So thank you for listening.
One thing that was very, very good, Sharon. One thing that I think is important about what Sharon said, come sit over here so if anybody has questions, is that you got to get it to the point of care. So you got to get it to the bedside nurse. And it's evident that we are not getting to the bedside nurse. And then, of course, when you talk about home care nurses, maybe it's morning, but we really are not in the U.S. getting it, and that's another concept of point of care. Questions? Comments? Disagreements?
Hello?
Yes.
Can you hear me?
Yes. Yeah.
I'm Barbara Cowie. I'm a clinical nurse specialist. I work in Toronto in rehab and complex continuing care, and I'm a nurse continence advisor. Thank you for your wonderful presentations. Very interesting. I have a few questions.
Okay.
and just a few observations. One about clinical guidelines is the actual uptake. And I've been working on improving catheter care practices within our organization since 2005. And there's a disconnect between the recommendations in the guideline, in various guidelines and shifts in practices. And one of the most frustrating for me has been the recommendation around not routinely irrigating manual irrigations with patients with long-term indwelling catheters, and we still get medical orders from our urologists for these irrigations. Some of the strategies has been through policy work and through conversations with the urologists and sharing the literature, but still a preference and a feeling that it helps with extending catheter life, and there's very little strong evidence in terms of the length of time that a patient should have a catheter in place, and a disconnect between the guidelines and how these catheters are regulated, and the class that they're regulated in. So they're regulated as being as a 30-day device. And so in the guidelines, it's recommending that we don't arbitrarily change catheters at a fixed time. But there's a disconnect between the guideline and how the catheters are regulated. And so it makes it difficult in terms of negotiating the length of time. And we do track the life of the catheters and change them based on the life of the catheter. But there's nothing really in the literature to support how long is too long to leave a catheter in place. That's just some of my questions.
There's a couple of things that you bring up there. And the one about the irrigation I hear all the time, especially long-term home care patients. I've been catheterizing my mom for the past 10 years. You know, it keeps the bag clean. And you're right, the guidelines discourage it, but I don't stop practices like that. Whenever it's been done within the family, I just don't. I mean, first of all, you know, even if you tell them no, they're going to end up doing it because they believe that's what works. And there's no long-term guidelines on any of this. So I think that, you know, that's what we do. Now, what happens is, as far as changing, I think is an important point. We should not have arbitrary changing. It should be based on assessment, and the nurse should be assessing what's going on with that patient. So it may mean that a catheter needs to be changed every 2 weeks. I had a patient who, for 3 years, an ambulatory patient, who I changed his catheter every 3 weeks, a lot of comorbidities, never had infection. If I would go 4 weeks, he would. I switched him from latex to silicone because I thought some of his catheter-related things were latex-related, which we have no data on. We don't know what a latex allergy is within an indwelling. So it was really based on my assessment, all right? So the issue is it really gets back to assessment of the individualized patient, which I don't think nurses are very comfortable doing. And that's why we got these arbitrary things. But you're right, the guideline states there should be no set changing. And that can be difficult for practicing nurses.
I just want to make comment on that as well, because we experienced the instruction or the request by the urologist to a community nurse to say, to avoid any blockage, could you actually do a weekly flush? And then the community nurses who I've educated are saying, well, we shouldn't be doing that. So they email me and saying, is that right? So then there's that negotiation between the urologist, the nurse, and myself to be able to come to some type of agreement, because even though the guidelines may support us, there is anecdote. There is anecdote, experiential stuff that actually feeds what urologists may want to do and then what community nurses think is right to do as well. And so we do have that disconnect. And it's hard because there isn't one consensus document to go to say, this is what we follow. Because there's so many different guidance out there. And so how we can pull that together, that is actually recognized throughout the whole profession, so that we use it as our guidance across the professions, rather than having all this juggling between us.
I just finished, I've actually done 7 studies with people with indwelling, and I'll be speaking later, but 40% of the people irrigate, the ones that have been in my studies, and they may have had the catheter for a year, 39, 40 years. So it's not a small percentage. The only guidelines I've ever seen were developed in Scotland at the Teaching Urological Research Center in the Glasgow, I think it was Glasgow. It's a while ago, in the 70s, late 70s, by Ferry and Glenn, and they came up with 3 criteria: difficulty removing the catheter, frequent obstruction, or frequent urinary tract infections would mean that they should be changed between the 2 and the 4-week period, and that they should be observed by a visiting nurse, which they were able to do, on a weekly basis to assess the catheter as to whether it was starting to block. People with none of these criteria could go in the 4 to 12 week. I think actually at that point they said 4 to 8 week category. So that's the single study, and it was, I should say, single article I've seen about criteria, and it was based on clinical practice and best expert knowledge and a consensus document, not based on research. The other thing that we haven't talked about, and I'm sure a lot of you are aware of, is that the persistently blocking catheter may very well be colonized with Proteus, and Proteus is the one that puts out this much compared to 20 or 30 microorganisms that put out a lot. And if you have Proteus in the urine, you might very well have blockage every couple of days. And so extending the life of the catheter so that it's not being changed and blocked that frequently is something that they're trying to negotiate and figure out how to deal with it. It's a big problem.
Yes.
Hi, I'm Veronica Hagger. I'm a continence nurse specialist in the UK. In the UK, we very much talk about long-term catheters, and it seems to be a catch-all term for anybody whose catheter doesn't come out within a few days. And what we've tended to, or I've found very much, is long-term catheter can mean anything. It can mean the fact that the decision has been made that the catheter is in long-term or even permanently. But also it can be about what the catheter is actually made of. In other words, it's a 4 to 12-week catheter as opposed to a less than 4-week catheter. And we frequently see documentation where a nurse will have written, patient has a long-term catheter, when actually what they're meaning is that they've put in a hydrogel or a silicone catheter that can last for 12 weeks, not that the decision has been made for the catheter to be in long term. And I think we really need to make a real move towards our terminology with regards to catheters and the decisions about documenting when a decision has been made that a catheter is in long term, or possibly even changing our wording so that we're talking about permanent and temporary catheters. And when we're talking about materials that catheters are made of, that we're talking in terms of recommended of 4-week or 12-week usage.
I think that causes confusion.
Yeah.
Yeah, I think that the problem that I think we all grapple with is there's no evidence on what, and you're right about the long-term versus short-term. We're going back to whenever the retention catheter came out. That was what the indication. And now we know with bacteriuria and that, we know cutoff times, but, it's really based on not a lot of evidence. And I think that's the major concern. I will tell you that what's happened in the U.S. is regulatory. So it's tied to financial payment. Like you said, the never event, and it's true. So if you keep a catheter in and they develop a urinary tract infection, it's now in acute care hospitals and rehab. The insurance, you will not be covered for the treatment of that infection. And we're looking at millions and millions of dollars of lost income for hospitals. They have to pay out of their pocket. So you have seen a decrease in use. Again, and I think we're bypassing the patient again, but that's the way they did it.
I think that highlights the incentive. We don't necessarily have those financial penalties in the UK, and it is about achieving hearts and minds from our clinicians to reducing quality and improving the patient experience. So it is we haven't got the financial penalties that you have. So we are doing it by surveillance and good practice, but it doesn't always work.
yeah, one more question and then we'll have a break.
Just 3 points. I'm a urologist. And the first thing is we're talking about catheters, but all bladders are not the same. And so all bladders don't tolerate catheters the same way. So the issue is a lot of times not the catheter, it's actually the bladder that you're looking at. In the same way, all catheters are not the same. So when we talk about catheters, we always talk about the outside diameter of the catheter, but if you actually cut through catheters, the inside diameter is what matters. And depending on which manufacturer's catheter you have, there's a huge difference in the inside diameter, which has an impact on what's going to happen with a catheter. The other thing is, it's a great comfort to know that urologists and other places are not consulted about changes in catheters as well. In my health region, you wake up one day and you're presented with whatever you get. And what you get is latex-free, so the health region looks good, but it's also the cheapest catheters on the market. And what you find is they kink behind the Y where you inflate, so people wet themselves. The balloons deflate, so they fall out, people wet themselves. So again, catheters are not all the same. So when we talk catheters, there's a huge variation in that. And the final point is that a lot of what we do with catheters is anecdotal stuff that we learn at medical school and elsewhere, and which we just continue. And one of the things is around this bladder irrigation and leakage of catheters. And we forget, first of all, that a catheter doesn't keep the bladder empty all the time. We know now from research it fills and empties. Secondly, the internal diameter of the catheter determines how much urine is going to come out. So if you get a bladder that's actually irritated by the catheter and spasms, they leak. So now you start irrigating that bladder and the leakage gets worse and worse and worse. You start filling with a catheter, it gets worse and worse and worse because we think it's blockage. It's not blockage, it's the bladder.
Those are all really good points, but I just think it really, you're talking about the diameter catheter, that's a real important point because silicone supposedly has a bigger diameter internally and thinner wall, but I have to tell you that most of the silicone catheters we have are stiff, and patients complain of them. They hurt. And so, it's just like, you want to do this, but then this problem occurs. I have to stress you, there's nothing in research in this. And you're right. So we say these things, and a lot of it's based on what we've always done. And I don't know. And I think that the point is that they're causing problems. So we're seeing us being more and more regulated.
And I think it points out that we're still using a catheter that it's actually, even though we're using it in modern healthcare, it's so outdated and obviously yields all these problems. So we need to engineer a new catheter. And you showed the Duet. Is it the Duet Duet catheter? There was the Biomed Centre in Bristol Urology Institute in England had considered prototyping a new type of catheter, but at the moment we have what we have, and they cause so much trouble. And when clinicians come to me, it's like, okay, can we remove it? Why is it there? Let's revisit the original issue of why it was inserted, and let's get it out. Let's do trial without. Let's do a trial without, and if the person's incontinent, let's actually get some treatment going and actually look at alternatives. But it isn't easy, and there are some people we just can't avoid using a catheter. But I think we need to get some more research.